When both doctors are satisfied that the preconditions have been met, they are able to move on to the next stage, the clinical examination. The tests, examinations of brainstem reflex activity, provide information about the integrity of the brainstem at various levels and should be conducted by the two doctors working together. The Code of Practice directs that the tests must be carried out twice and wherever possible by the same two doctors, one performing the examination on the first occasion with the other observing, and then switching roles for the second set. There is no time interval specified between the two clinical examinations, other than that required for physiological stability to be restored after the apnea test. Some doctors use the period between the tests to talk to the family. Families are increasingly being invited to observe the tests being performed, most typically the second set, and they should be warned of the possibility of spontaneous and reflex spinal movements. We will now go through each element of the clinical examination in more detail, working in a craniocaudal direction and starting with the pupillary light reflex. There should be no pupillary reflex response to light. The pupils should be fixed with no direct or consensual response. Note, there is no requirement for the pupils to be the same size or the same shape.
Do you mind turning the lights down?
The test should be undertaken in a darkened room using a bright light source.
In both eyes and looking for a lack of reaction.
It may not always be possible to examine both eyes because of trauma or previous pathology, but at least one eye should be accessible.
There's no direct or consensual response.
No, there's no reaction.
Next, we go to the corneal reflex. The corneal reflexes should be absent bilaterally with no blink following stimulation of the cornea with sterile gauze or saline eye drops.
Okay, so you're just going to feel a little...
Note that any contact lenses should be removed before conducting the examination.
No corneal reflex.
And that it is the cornea, the coloured part of the eye, and not the sclera that should be stimulated, as the cornea is more sensitive. Care should be taken to avoid damaging the cornea when performing the test.
On the left-hand side.
There's no reaction.
We now examine whether there is any motor response within the distribution of the cranial nerves to a centrally applied painful stimulus, for example, supraorbital pressure.
So you're just going to feel a little bit of pushing just above your...
Although the primary endpoint is motor response in the cranial nerve territory, any peripheral response to supraorbital stimulation should also be assumed to be a brain-mediated reaction. Some clinicians will also apply a peripheral painful stimulus, for example, to a nail bed.
Just a little bit of pushing on your finger now.
Again, looking for a central motor response. If there is an isolated peripheral response to peripheral stimulation, this should be regarded as a local spinal reflex that does not invalidate the diagnosis of death.
No reaction.
No reaction.
Next, we look for reflex activity from the lower brainstem by attempting to elicit a cough and a gag reflex.
Best expose his chest and abdomen.
We use a full-length endotracheal suction catheter to attempt to trigger a cough reflex by stimulating the carina.
And there's no cough reflex there.
No.
And we use a Yanker sucker to stimulate both sides of the pharynx to attempt to elicit a gag reflex. Note that some doctors will perform this under direct vision using a laryngoscope, although there's no absolute requirement for this.
Uvula using a laryngoscope, and then stimulate each side in turn.
I can see no gag in his throat either from externally. Thank you.
We now move on to the oculovestibular reflex, which is sometimes referred to as the cold caloric response because it involves irrigating the tympanic membranes with ice-cold
Should we just
fluid.
look inside his ear, make sure there's no wax?
We start by examining the external auditory canals with an otoscope to ensure a clear access to the tympanic membranes.
No perforation of the eardrum.
Next, the head should be flexed to 30 degrees to the horizontal, and 50 ml of ice-cold water or saline should be injected through a quill into the external auditory canal over a minute. The eyes are held open during the irrigation with both doctors looking for any sign of eye
There's no
movement.
reaction at all. I'm sorry, sir.
The final element of the examination is the apnea test. Is the patient able to breathe when taken off the ventilator and exposed to an adequate respiratory acidosis? This test should only be performed after all of the brainstem reflexes have been shown to be absent. This is to avoid exposing the patient to what might be potentially harmful hypercarbia and hemodynamic instability should there be any residual brainstem function. The aim of the apnea test is to expose the patient to an adequate respiratory acidosis, that is, an adequate stimulus to breathe during a 5-minute period of disconnection from the ventilator in as controlled a fashion as possible.
Just the ventilator, please, so that is receiving 100% oxygen.
To help ensure this, before disconnection from the ventilator, we ensure that the patient is cardiovascularly stable. We pre-oxygenate the patient.
Take his minute ventilation down by reducing his rate to 15.
And we reduce the minute ventilation delivered by the ventilator to allow a mild respiratory acidosis to be reached before disconnection.
What's the PCO2?
CO2 of 6.
6.0. So it's going to be greater than or equal to 6.0, it is.
The patient is disconnected from the ventilator when an arterial blood gas shows that the arterial CO2 is equal to or greater than 6 kilopascals and that the blood pH is below 7.4. Although the CO2 may need to be higher in patients with chronic CO2 retention or in those who have received recent intravenous bicarbonate therapy. It is important that the patient is actually disconnected from the ventilator in order to avoid cardiac pulsations from triggering ventilator-assisted breaths or respiration being resumed by the ventilator's apneic mode.
Uncover you again, sir.
The patient is exposed down to the umbilicus. It is important that you are able to see the abdomen as well as the chest, and observed for a minimum of 5 minutes for any sign of respiratory movement.
Do you mind switching the ventilator off?
The use of a respiratory monitor and end-tidal CO2 monitor may be helpful. During disconnection, oxygenation is maintained by using a Maplesome C circuit with CPAP, which will help prevent atelectasis and allow any patient breaths to be easily observed. Alternatively, you can insufflate with oxygen at 5 litres per minute down a suction catheter placed in the endotracheal tube. However, it is important to avoid high oxygen flow rates because this might wash out carbon dioxide. It is not uncommon to observe abdominal pulsations from the aorta during the test, and this can be confirmed by timing the pulsations with the ECG monitor.
No movement.
After 5 minutes of apnea, another arterial blood gas sample is taken to confirm that the CO2 has increased by at least 0.5 kilopascals and that the pH has fallen still further.
0.5, it's risen by minimum 0.5, so 7.3.
At the end of the apnea test, a recruitment maneuver should be performed before the patient is reconnected to the ventilator. Gas exchange should be allowed to return to baseline in preparation for the second set of tests.
Alex, are you satisfied that death's been confirmed following the irreversible cessation of brainstem function?
I am, yes.
Death is diagnosed and confirmed after 2 sets of tests demonstrate the complete absence of brainstem function, because we can now be confident that the patient has lost the capacity for consciousness and respiration, and that, on the basis of the assessments carried out in stage 1, that this is irreversible.